We are pleased to welcome Richard Roberson, President and CEO of the Mississippi Hospital Association. Richard, thanks for coming in.
Thanks for having me. Happy Friday.
Yeah, same to you. How long have you been in this role now?
Since September of last year.
Okay. I thought it was just under a year.
Yeah, under a year.
Yeah.
I've been with MHA for a while before that. Have been in private practice, worked under several different governors when I was with the state, with the Attorney General's office at education, Medicaid, private practice. So
you bring a lot of experience.
Checking lots of boxes.
Yeah.
Trying to figure out what I want to be when I grow up.
Well, healthcare is incredibly complex, as you know, and there's a lot of government policy at all levels of government, certainly state and federal, that involve healthcare. I've often said, Richard, that to a great extent, our federal government, our state government is largely in the health insurance business when you think about just how much money flows through Medicare and Medicaid, TRICARE, and so forth.
Well, just, Gerard, so that's a great point. In Mississippi, for our hospitals, if you look at their patients and their payer mixes for those patients, who pays for their patient services that they see in hospitals, it typically runs about 45% Medicare/Medicare Advantage, which is kind of the private derivative of Medicare that a lot of folks choose now.
Yeah.
About 20% is typically Medicaid. Another 3% or so is TRICARE, and that tends to be concentrated around some of our military installations. So, you're talking about Columbus, Meridian, Hattiesburg area with Camp Shelby, down on the coast, of course, a lot of military presence.
Okay.
So just those payers alone, you're pushing 68-70% that is government paid in some shape, form, or fashion. So it's a lot. And then, typically another 8 to 10% are uninsured. They don't have coverage. And that leaves about 20% or so commercial.
The highest payers.
The highest payers. And of that commercial mix, what we count in that are some of the federal marketplace exchanges.
Yeah.
So you've still got a government presence
commercial
there.
Coverage.
And those have grown over the last few years. They've pretty much doubled since the pandemic, the enrollment in the ACA marketplace exchanges. So that government presence in healthcare and who's paying for services, it's primarily in Mississippi and in most other places, it's going to be majority government payer of some shape, form, or fashion.
It's a great point. I'm glad we talked about that, because I don't know that the folks in the public know that when hospitals are looking at their payer mix and their source of revenue, that, again, a great deal of it is coming from these various government programs, including the subsidized coverage in the exchanges, which we're up to, 21, 22 million or so across the country.
Across the country, that's about right. I think the last I saw in Mississippi, it's now pushing 170,000 or so in the exchange. If I'm remembering that right.
200 is kind of what was in my head.
And so, from a provider perspective, when you talk about negotiating rates and negotiating payments, you don't really negotiate with Medicare. I mean, Medicare has their own standards and their own way of paying for claims, whether you're a physician or whether you're a hospital or any other type of healthcare provider. So Medicare's pretty much what Medicare is going to be.
Yeah.
So, and Medicaid is the same way. The statutes regarding Medicaid in Mississippi define what a lot of the providers get paid. It's maybe 1% of Medicare. So that's statutorily defined in many cases. So providers don't really get a whole lot of flexibility to negotiate their rates with government payers. It's pretty much, it is what it is, and you just kind of have to try to make it work.
Yeah.
So, it's an interesting dilemma in some cases, and but what I also like to say, and what a lot of people don't realize, I think, our Mississippi hospitals are the lowest cost in the country. For inpatient and outpatient expenses, Mississippi for years has ranked as the lowest state cost-wise, expense-wise in the country, and some of that's out of necessity because, when you've got a majority of your payers, government payers, you got to try to make that work and try to fit up under that dynamic. So, Mississippi hospitals do a great job of keeping a lid on their cost. Not that it's cheap anywhere for health care, but it's better here than it is really in every other state, in my opinion.
So, Richard, we've talked a lot on this show, and especially the last couple of years in the state in general, about this idea of expanding Medicaid, and we've been through that here on the show. That's exactly what that means. And so I don't want to dwell on that. We beat that horse to death, and of course, not surprising, that didn't really get a lot of attention this session. But in doing so, in just researching for the show, I just happened to review lots of the financial statements that are available published by the hospitals in Mississippi, many are cash flow negative. I mean, they're upside down. How are we doing these days?
Well, there's a lag in those reports that get put out. So you're probably seeing a couple of years data.
Annual reports,
current. That's right.
Year old, yeah.
Yeah, so you might see ones that maybe are 2023. 2024 stuff should be coming out soon.
Just starting to. Depends on their fiscal year.
That's right. Yeah. And so, what we've seen up until the fall of 2023 when Medicaid and Governor Reeves put out a new methodology for payment that had been catching on across the country with other states, to go to an average commercial rate, basically for your Medicaid population for hospitals. Mm-hmm. But what we had been seeing before then were just what you described: negative cash flow, increases in expenses, decreases in revenue, increases in cost. Much of that was related to what came out of COVID, where everyone's cost, and we still see that, cost going through the roof after COVID.
Especially labor costs, right?
Cost of labor. I mean, when you were having to pay folks $15, $20, $25 an hour that prior to had been making $10 to $15 an hour, doing different things in a hospital, not clinical services necessarily, but just folks that have to be there to fix things, to prepare the food, to prepare the meals, to make sure people get around the hospital in wheelchairs. Mm-hmm. Folks that are vital and critical to that hospital's mission. Everyone saw a pay raise. And then, of course, everyone pretty well publicized that nurses' salaries and compensation was going up during the pandemic and after, to try to make sure that we had enough folks to care for people. And that was the big concern during COVID for sure.
So that waiver that the governor was involved in as well, I mean, he was a pretty strong proponent. Talking about the Medicaid waiver, the payment. Yeah, was amounted to what, $600-700 million, right? To the hospital industry.
Yeah, the net impact of it was about $750 million at the time. I think it's a little bit less. I think the numbers went down a little bit. I think maybe this year is about $40 million less than what it was last year for that program. So, but at the time, it was a $750 million net impact. And, hospitals pay the entire state share for that. In the Medicaid program, the feds put up some money and the states put up money. That's based off of several different things, primarily based off of your economic condition in your state,
per
your
capita
poverty
income
levels. That's right. And Mississippi has for years gotten the highest federal match rate, so we get more federal money than other states do for our Medicaid program. So, but for that supplemental payment program, hospitals pay the entire state share. So it was the single largest benefit for hospitals at that time. It was also a large increase on their taxes that hospitals paid, but when you're getting a return on that investment, it was worth it. So so that was a massive shot in the arm that frankly has kept many of our rural hospitals afloat for the last few years.
So are you concerned that there's some discussion? I mean, I know you're concerned about a lot of things going on in Washington right now, but where there's some scrutiny over that structure about the way that hospitals essentially pay taxes so that they can tap more federal and state money in the form of Medicaid reimbursement.
Yeah, and so those taxes have been around for 40 plus years. The provider tax rate, it's capped at 6% of net patient revenue. And the aggregate. Now, you can tax it in different ways. You don't have to tax it based off of revenue, but whatever dollar amount you tax, and the aggregate needs to stay below that 6% ceiling for all providers, not just hospitals. And so we're very concerned, as are my colleagues in other states, since I've been in this new role, when I've been to different meetings with my peers in other states. This provider tax issue is a big topic of conversation, because what states did from a financing perspective is to say, well, if we're going to give these special dedicated funds to this particular type of provider, that particular provider needs to step up and pay a tax for it,
sure,
rather than taxing from the general fund and that sort of things.
Well, I'm sure you know what got the attention in Washington is California, and the way they've been operating their program. They figured out a way to use that.
There are a lot of states that have been pretty creative on some things.
But they're insuring illegals.
Well, there's a lot of stuff.
California's.
Well, yeah. I mean, look, there's a lot of things that have been put into these programs across the country that for years have frankly kept doors open at many hospitals.
Yeah. Well, that's why I asked if you guys are concerned about possible scrutiny and maybe even banning that as a means to tap more federal money.
Yeah, what we're worried about is the ceiling coming down, which then would take hundreds of millions of dollars out of that program potentially.
Well, if you can hang around,
the state tax, there's an implication on the other side.
I get it. If you can hang around, we keep talking.
I'll be here.
Yeah, we got Richard Roberson, President, CEO of the Mississippi Hospital Association. Coming right back. All right, so we're talking to Richard Roberson, President, CEO of the Mississippi Hospital Association. So before we went to break, Richard, I mean, I know you guys are keeping an eye on a lot of stuff going on in Washington. Something else, of course, you're well aware of is we've got enhanced subsidies that
Yes.
are covering a lot of Mississippians. They're enabling them to get insurance in the ACA exchanges that are scheduled to expire at the end of the year.
That's right.
The enhancements are. And should that happen, that likely would result in many of those folks just going out of coverage. And that could put pressure on the hospitals.
It definitely would. Like I said, I think the numbers have doubled since those subsidies have been in place. And so, our uninsurance rates, our percent of uninsureds has gone down since COVID. It went up immediately when everything kind of blew up in March and April with the whole world and people losing employment. And then folks started to get coverage through the exchange. They got coverage through Medicaid. Those provisions were locked in for a number of years. And then when some of the disenrollment with Medicaid happened, you started seeing Medicaid numbers go down and the exchange plans going up a little bit. And so any change in that affects the uncompensated care that hospitals are providing, which even though the numbers went down because the cost went up, it costs more to take care of patients.
Yeah.
So uninsured patient numbers in raw numbers went down, but the cost of caring for those patients went up. So it's just math.
Yeah.
So we really didn't see a dramatic or a corresponding change in uncompensated care costs because the costs started going so high. So, so it's a crazy. It's kind of like those balloon animals. You squeeze one in, and another end pops up, and you try to twist it and turn it and make it look like something pretty at the end of the day.
So something else that I'm sure you're watching is concerns about this enhanced Medicaid payment program reform that we're under a waiver on. We were just talking about. I mean, that's also being considered as something they want to terminate in Washington.
That's right. And so, so that program for Mississippi, again, it's hundreds of millions of dollars that are helping keep many of our hospitals, big and small, in the black.
Yeah.
And, but for that program, we're going to see a lot of things walking back. So a lot of my peers across the country have been talking about that and what CMS does with that average commercial rate may change. It used to be pegged to a Medicare rate, which is lower than a commercial rate. So if CMS were to go back to that standard, then that's hundreds of millions of dollars that are going to get taken out of hospitals. So
plus, we already have a low commercial rate in Mississippi.
We already have a low commercial rate in Mississippi. What we have is good, but it's lower than other states. Our percent of employment covered commercial care is lower. That wasn't a thing until about 100 or so years ago, coming out of the 20s and 30s when employers started pushing.
Yeah, it's World War II.
They came up with a way to attract folks to come into the workforce and be more competitive, and so businesses were offering employment covered insurance services as a way to attract people back in. Mm-hmm. And that's when we really got into the advent of employer-sponsored coverage. Mm-hmm. And it's great when you've got it. But man, it's scary when you don't.
Yeah.
And so it's a, look, the whole healthcare fabric, it is very complicated. It's a quilt, and sometimes it's a good patchwork, sometimes it's not so good. And again, I talk all the time about our hospitals in Mississippi providing good quality services. We typically are in the 20s or so on those leapfrog studies on quality, and our costs are the lowest in the country. So I think across the board, our hospitals are doing as good as they can do to take care of their patients and providing good quality at a low cost, which is really the goal for everything, right? You want a good quality at the lowest cost you can get it. But it still takes revenue to keep the lights on and to employ physicians and nurses and folks that work in food and environmental services and keep the hospitals clean. And it's not just hospitals, it's our physician clinic offices, it's our therapists that provide care for speech therapy, occupational therapy, physical therapy, mental health services. And all those things are important in the whole fabric of healthcare. And, it does take money to provide those services.
So we had Representative Dana McClain on the program a couple of weeks ago talking about legislation that she introduced that would require hospitals to maintain rape kits
Yes.
She made the case for that. What's the Hospital Association's position on that?
Yeah, so we met early on back in January and said, look, there's some things that we see in this original bill that we need to tweak just to comply with EMTALA. Hospitals are under a federal law that was signed in the 1980s by President Reagan.
Ronald Reagan.
Yeah, Reagan signed that law, and it provides that hospitals shall treat, first screen, diagnose, treat, or transfer patients that come into the emergency department regardless of their ability to pay. And so there were some provisions that were in the original draft that we said, it potentially conflicts with federal law, which anytime federal law is conflicted with, federal law is going to supersede it.
Right.
So let's try to make this thing effective if we can. And make it comply with federal law. So that's what we have suggested. But we have from the beginning, and I said this from the very first meeting I had with folks and with Representative McClain on this, you're not going to find a bigger advocate for victims of sexual assault than me or than the Mississippi Hospital Association. As a husband, father of daughters, that's something near and dear to my heart, and we're going to support that, and I'm glad to see that the legislature stepped up and passed that, and I think Angela Hill from the floor of the Senate made sure people knew that MHA had supported that bill.
I mean, so you don't have any, the association doesn't have any conceptual objection to this?
Other than our suggestion on fixing the tweak with the EMTALA provisions, which I think that's been taken care of in this ultimate bill that came out, where they've got language that tracks with EMTALA that talks about what the hospital would do with treating and screening and treating, and that's where we were all along with all that. So,
as I recall, Richard, the EMTALA original legislation actually states that the hospital must stabilize the patient, something to that effect. Remember that?
You got to make sure the patient is stable before you transfer them.
Okay.
And so you can't just send a patient out that's bleeding out or something crazy.
Even though they can't pay.
Put them on a truck. Yeah, that's right. So EMTALA requires that hospitals provide those services in the ER setting regardless of ability to pay. So, someone gets wheeled in there and they've been shot, bleeding out. You don't stop them and say, hey, what's your form of insurance and are you going to be able to pay the bill? And if the answer is no, I'm sorry, we're going to have to roll you back out in the parking lot. That doesn't happen.
Hasn't since 86.
That's right. And I'm not even sure some of that was happening before 86, but it certainly hasn't since then. That's right.
I mean, it's law now.
Yeah, that's right.
And the L stands for labor. So if someone shows up at the ER and they're in labor, you got to take care of them.
You got to take care of them. You don't stop and ask mom, hey, can we get your insurance information here and make sure that that you're going to pay us before we deliver that baby? That's just not what they do.
Probably the only industry in the country that's like that.
I would imagine.
You can't stop and say, hey, can you pay before we take care of your...
I'm probably not going down to the Kroger on 55 after this interview and bagging a bunch of groceries and taking them home just because I'm hungry and saying I'll pay you later. That's probably not going to work too well.
I agree. House Bill 17, white, brown bagging. What's that all about?
So, that was a great bill, and I really applaud our legislature for passing that. And, it's been a challenge, particularly for patients that are receiving physician-administered drugs. So think about patients that go for cancer treatments. Many times the insurance company will say, well, we'll ship the drug to you. Don't order it through your supply chain. We'll ship it to the hospital or to your clinic. And sometimes it gets there on time, sometimes it doesn't. In other cases, like for brown bagging, they may ship it to the patient's home. And so then that patient shows up at the doctor's office and says, here, I've got my medicine. Will you shoot it in my arm? And from a physician standpoint, you hope that there's been a secure chain of custody. You hope it's been properly refrigerated. You hope when that drug arrives at your clinic, you've got room in the refrigerator to store it. But you don't necessarily know from a supply chain perspective if you will or not. And so, I can't take my car up to Firestone and take a new set of brakes and say, hey, I'd like for you to put this on my car. They're going to say, no, we've got our own way of making sure we've got secure chain. So we'd had concerns, and folks had expressed concerns about chain of custody, legal liability. Putting my lawyer hat on, if somebody's handing me something, I don't know where it came from.
Sure.
Sometimes that's a concern. So, look, I think it's a good bill that's focused on patients, and hopefully this is going to help patients that really need those most intense types of drug therapies get the drugs that they need on time with the provider that they need to get it from.
Gotcha. In about 30 seconds, can you talk about 662 presumptive eligibility?
Yeah, so presumptive eligibility is just a great way to take care of pregnant women before they get determined eligible for Medicaid. It takes maybe 2-3 months before they get that eligibility determination. What this does is allow providers to say, we're going to presume you're eligible for Medicaid so we can go ahead and start preventive care, prenatal care now, and that mom and that baby don't wait 3 months.
That was passed last year, wasn't it?
It was passed last year. They had to make some tweaks to it because of some federal conflicts in there. Again, trying to comply with federal law.
Gotcha. Makes total sense. Richard, thanks for coming in.
Thank you for having me. Always good to visit with you.
It was great. Richard Roberson, President and CEO of the Mississippi Hospital Association, has been our guest. Right back with you in the Element Wealth studio.